Well,
Okay,
tēnā koutou, welcome everyone to the third in our webinar series from the New Zealand Telehealth Leadership Group. This webinar follows on from our last webinar on equity a couple of weeks ago, and you can find that again on our website. So you can go back and listen to any of our recordings. Now, we're very fortunate today. We've got a panel which is made up of a number of our New Zealand Telehealth Leadership Group, and to moderate that for us is our panel moderator is Scott Arrell, who is the Chief Executive of NZ HIT and also a member of the New Zealand Telehealth Leadership Group. Thanks, Scott.
Thank you, Ruth, and kia ora koutou to everybody that's joining us tonight. I can see the numbers are climbing now. I think we've just hit 117 participants within. That must be a world record. It's kind of like from nearly zero to 120 now in 30 seconds. So, hey, just welcome to everybody. And as more people start to come on, we'll get going. But tonight's session is a follow-on from two previous sessions on telehealth, focusing on this particular topic. It's by no means the last either. There's plans to do more. So keep an eye out for the promotion of the next lot of webinars that are coming up. So we're focusing tonight on clearly telehealth, and that's kind of broadly defined as healthcare provided at distance, including the use of the likes of phone, video, in-home monitoring, that type of thing. But tonight's focus is specifically more on the use of video in the telehealth setting, and looking at areas such as security software and hardware. We may touch on privacy, but we won't get into that in too much detail, because that's almost a sort of a session all on its own, really. So while we might touch on it where it comes into play in terms of security, we won't be going into too much detail. Once everyone's done their introductions, I'll start to ask questions and to either point them at specific people in the panel, or just open it up to the panel to have it to answer. Finally, before we get into introducing everyone, just I want to thank the Telehealth Resource Centre, specifically Andrew, for all the hard work that he does to do all the technical things to put these webinars on, and then also particularly thank all the members of the TLG, and especially those that have joined us on the panel tonight. I think when we were looking at who would be on this panel, it was pretty obvious that we had so much expertise around the table. Why not draw on that experience and knowledge and bring them together as the panelists tonight? So we're now at 140, just getting up close to 150 participants. So I'm just going to introduce as such each of the panelists. As I do that, they'll just actually talk about themselves, explain what their background is and their interest is in telehealth. So firstly, we've got Dr. Carl Cole. So Carl, could you, I'll just pass over to you.
Oh, hi, thank you. Yes, I'm GP by trade, I suppose. 5/10 trip GP and a clinical director, Chief Clinical Information Officer of Health Alliance, is the shared care agency, shared services agency for the Auckland area. More into management stuff now, but I have a lot of experience back with Lucy and Roy around telehealth from Army days, working out that it's actually much better to have telehealth consultations when you don't know what you're doing in the remote areas to experts, and how much I realised that was so much the future. And I was just joking with Lucy earlier, 10 years ago, we were trying all sorts of ways of justifying telehealth and using the beginnings of telehealth across the beginnings of broadband, and now using it extensively, like many of us, in the last 8 weeks in my daily practice. I think that's won't take any more time, Scott.
Okay, thanks, Carl. I really appreciate you coming on. I know how busy you've been, and in fact, all the panelists are busy, and so are actually everyone that's attended. It's been such a crazy period as we go into a bit further into level 2. Dr. Marshall Hollister-Jones is a GP from Tauranga, so I'll pass over to you, Marshall. You better explain where you actually are at the moment.
Oh, I'm on holiday in Queenstown, but there we go.
Hey, good on
it's
you.
tough, but it's tough, but someone has to do it, Scott. Well, first and foremost, I'm a full-time GP. I wear a few hats. I'm a business owner, so I own a large group practice, and I've got a long involvement in information technology projects at a local and regional level, mostly around integration between primary and secondary care and seamless care and integration. And have seen some successful projects roll out over the years. We've had telehealth pilots in the Bay of Plenty historically, which haven't really flown. And again, a little bit like Carl, you know, it's been full speed in a different direction since we hit lockdown. And we've been experimenting in our practice with video consulting over the last 12 months, but it's now full rollout, and we've set up a virtual practice, and we're busy enrolling patients in that and moving ahead.
Oh, that's fantastic. And yeah, thank you for going on holiday. Actually, I think that we're all being encouraged to get off and support our local businesses and our tourism. So good on you. And I'm sure you've earned the break as well. The next person I've got on my list is actually Kyle Ford, but Kyle's going to join us in about 20 minutes time. So we'll come back to Kyle when he does join us. So I'd like to just pass on now to Faustin Roman and just introduce yourself there.
Yeah, thanks, Scott. Kia ora, everyone. My name is Faustin Laurentiu Roman. I'm the Chief Information Officer for Patients First and also Director of Medical IT Advisors. And my focus is on cybersecurity and privacy, in particular to advance the cybersecurity maturity and digital transformation of the primary health sector. I've been involved with Patients First for about 2 years now, and also part of the telehealth leadership group for possibly same time, 1.5 years. Telehealth, it's obviously one of the digital areas of interest, and while I'm very excited to see the uptake of this technology, I really believe we need to understand the risks and ways that I guess are required to protect patient privacy while we are able to deliver services to patients. My background, it's actually in nuclear physics a long time ago. I also have a background in cybersecurity. As you can see, this background, it's actually a phishing link. I thought of making a little bit of awareness campaign for this opportunity. And I'm really excited to be part of this panel, and hopefully I will be able to just convince you to have some arguments that security is needed. It's an absolute requirement, and it's not really something in the way of progress or interaction with patients. It's actually an enabler, and I do believe we can have secure and easy to use systems. Where there is a will, there is a way. So happy to be here.
Yeah, thank you, Faustin. And all the way from Whangarei, the beautiful winterless north, so we have Roy Davidson.
Thanks, everyone. Kia ora. It's only the winterless north because it doesn't snow up here. But yeah, it's good to be here. And I'm a telehealth program manager based at Whangarei Hospital, as Scott said. I've been involved in telehealth for about 8 years now. I started off, for me, it was quite a personal journey where one of the projects I got in my early days was supporting the renal team here in Northland, basically communicate with each other, and they had a shortage of specialists, and they had a new satellite unit opening up in Kaitaia, and they had to find a way to actually support through technology this new satellite centre because they couldn't staff it. And so that was the start of telehealth for me, and gee, what an interesting journey it's been, and just to see personally firsthand the benefit that the technology can bring. And big shout out to Kaitaia and the people in the rural hospitals, and they're often so resourceful. And, you know, I see Sarah Clark's online. Hi, Sarah. You know, it's just a joy to work with groups that are really up for change and are quick adapters, and, you know, makes a big difference. And we've had a number of, you know, projects that have sort of come through in the years. We're doing, you know, multidisciplinary meetings, getting clinical teams talking together in primary care, and basically, you know, providing greater access to specialists and you know, hospital-based specialists, and also down the line too. So our specialists require support from, you know, the tertiary centres such as Auckland, and we're using technology to help with that. So one of my other hats, I'm also chair of the working group for telehealth program managers as part of the Telehealth Forum. And I'm delighted to be that chair. And I think probably our main strengths with people who we call ourselves at the coalface of telehealth here in New Zealand is that we have a strong network, and we you know, we learn from each other, we share our experiences. It's a very supportive environment, and we also have international links, which I think is a really great sort of a great thing as well. So we're not sort of focused just on our own patch. We're sort of eyes above the parapet, seeing what's happening internationally as well.
Thank you, Roy. That's great. And now Lucy Westbrook.
Kia ora. I'm Lucy Westbrook. I'm the Telehealth Program Manager at the Auckland DHB. So Roy and I do a lot of work together. I've actually got a nursing background, clinical and management. And when IT was first coming in, I decided that clinical people needed to be involved, and I jumped ship onto the health informatics side, which has given me a huge range of experience, and including in the international arena, where I first started to hear more about telehealth. About 7 years ago, I got asked to start in the role as the Telehealth Program Manager at Auckland DHB. And over the past 7 years, we've done various, well, they're not projects, we've established various bits of telehealth. And a lot of the work that we've been doing both nationally and locally is making sure that we've actually got the infrastructure to be able to do this. Because when we first started doing things, we were finding actually we haven't quite got the right technology, and we haven't got the right infrastructure. So I'm really proud to have been part of the COVID-19 response, and it's been amazing to see the rapid uptake in telehealth and things. And I think I've got to give a lot of acknowledgement to other members here on the TLG, and a lot of the work that we've been doing in the background over the years, opening up channels and things, and then the barriers that we had identified came down with COVID-19, and that's allowed us to really ramp this all up and things. So that's a little bit of my background.
Yeah, fantastic. Thanks, Lucy. Well, and actually, Lucy, you and I have known each other for quite a way back, and yeah, I've really been proud of you actually and what you've achieved there at the DHB.
Well, I've served on various committees and health informatics arena with a number of you, and I've done projects in the work arena with others.
Yeah, thank you. And Andrew, you joined us all the way from Christchurch, and as well as being sort of the hard-working backroom guy, making sure all the stuff works, you're a panelist as well.
Yeah, thank you. Thank you, Scott. Well, I suppose I wear a couple of hats. My name's Andrew. One hat I wear is for an organisation called Mobile Health. So Mobile Health, our core business is running a mobile operating theatre. So that theatre is quite well known. It goes around New Zealand and does day surgery, especially in the provinces. And that got on the road probably almost 20 years ago. And we've done 26,000 operations on that mobile format since then. And telehealth and technology has always been part of that story. So when the unit was built, we had telehealth fitted in there. So we had a whole lot of comms gear, a whole lot of video gear, bollard cameras, and a whole lot of cameras that could be controlled remotely. So probably over 15 years ago, that was used, for example, for nephrectomy was done at Christchurch Hospital, and we had surgeons from Brisbane watching that surgery and guiding that surgery going as it took place. So We've done a lot of video. We've done a lot of education to rural towns, especially. So we do hundreds of video links every year to provide education to those towns. But it has changed a lot over the years. I've only been involved for just over 10 years, and I do just remember one video link that we did, say, from Oamaru, for example, and we had connectivity here, and we had the whole about 200, or not even that, probably 100 meters distance. And this was really before Wi-Fi was around. So the technology we used at that time was a laser. So we set up some scaffold here and scaffold there across the car park, and we actually shot a laser. And you had to align the laser to be sent and received exactly. So there were gun sights that you'd slowly adjust, micro-adjust the laser. So telehealth used to be really hard, didn't it? There used to be technology and there used to be bad connectivity. But I think we've seen over the last few years, probably the last 2 or 3 years, that bandwidth's got a lot better. The software's emerged as a platform that we can do telehealth on, and hardware's got a lot better and a lot cheaper. So definitely there's been a rise in interest in the last few years, but gradual, and I think COVID's really pushed that along. So there's one hat I wear. The other hat is the Telehealth Resource Centre here. So that's probably one of many behind that, and probably the front line for that, for initial contact with, when people make contact through the telehealth website, they say hi to me. So that's me.
Fantastic. Yeah, thank you, Andrew. And look, we've got 155 participants. It seems to have topped out at that. So welcome. Oh, actually, 156 now. Welcome to you all for joining us. There was a great question here from Becky George that I thought would get us started, and just go to make sure I've got the right one here. So thank you, Becky. I think what do you think the benefits would be for a single source of advice about telehealth platforms? It feels like there are too many confusing and conflicting guidance provided at present. So that's I think how about I chuck that one at you, Roy, to start with, because I think that could generate a little bit of discussion. So what are your thoughts to kick us off?
Yeah, it's a great question, and you know, we definitely struggle with this one ourselves, because of course the key thing is, if there's a lot of platforms out there, we need to talk to each other. And how do we do that across platforms? And we spent a lot of time sort of 2 or 3 years ago with the the New Zealand Telehealth Forum and our leadership group, just trying to nut through this problem. And technically it's very challenging. Also commercially it's very challenging, because often it's a commercial decision around one vendor not wanting to play with another, or vice versa. And so that's a really tricky one. I mean, one source of truth. I mean, I think, what we've tried to achieve in the northern region with the kind of 4 northern DHBs and kind of the health sector as sort of in our area is to a degree trying to make it simple, and sort of the fewer choices there are, the better, in a way. And I know, that's, yeah, I guess the jury's out, but it does sort of seem to be the way for us at this point.
I quite agree with what Roy's saying. When we work in big organisations, we're often restricted to a very set process we have to go through for selection. But there are so many options out there, and the technology is changing all the time. We were starting off with the codec based room-based systems, and the move to software and the range of platforms that the consumer can get hold of, as well as what we can use in the health sector, has just become vast. And particularly all the social media channels have opened up this as well. So we've got a lot of challenges, and I don't think there's any one source, and because I don't think it's stagnant. And it will be driven by demand to some degree. The connectivity is our biggest issue. And as we want to do consultations, we need to be able to use this technology and be able to not just do video, but we need to be able to access records. We need to be able to pass information, between clinicians and patients, in both directions. So there's quite a lot of challenges here.
Yeah, definitely.
Yeah, I think, Becky, it's always important too to, if you can seek advice from those organisations that you're already linked in with. So if you're from a DHB, make sure you talk to others in the DHB. If you're from a PHO, make sure you speak to the PHO. And also if you're outside those worlds, talk to talk to some of those people involved or other people already doing telehealth.
Yeah, and say from a GP, actual practitioner perspective, Carl and Marshall, how would you, number one, answer that question, but then maybe that leads into how you chose whatever you're using.
Yeah, so I chose something against what my regions, and I was part of the panel that Lucy and Roy was restricted in, and a very good product it is, but it was chosen for the security and the ability to be flexible around APIs. But the joy of being a small business owner and a GP in the South Auckland area, and recently just did a big change of rooms from 1 room to 8 rooms, and quite a massive increase in lease. I had all the infrastructure in place, and being an IT geek, I had my big switch box and 1 gigabyte Wi-Fi everywhere, and I was able to do a very, very quick, what are the killer apps that would make the difference for me? So I actually had heard about DoxyMe, didn't bother with it because I was using Zoom across the region with Roy and Lucy, and found that the patient experience was, to me, was the key to getting anyone to use it. And there's a couple of features that just made it obvious, and I was assuming the video and the rest will just get there in the end with bandwidth, and it was secure. So I went with that, and I haven't looked back, because what I have found is when you've got a health specific subscription mature platform, it's changed even the last 2 months to suit what the world's wanting. It's helped me and understands the process. And you sort of remember, any of these platforms actually are part of a service product that need to integrate right across to making the appointment, deciding it's a video appointment versus a phone appointment, how to call back, waiting room that allows them to come in easily from just a simple text without a password, to take the photos they come in, to be able to take a photo remotely so they can hold their picture on the rash, and then it remembers the last position so it can re-photo, to be able to share the screen, be able to invite a specialist in or someone else to help do the video with you. And the process of it actually is just another way of delivering service, and it's horses for courses, fit for service, fit for the purpose. I have to have the notes with me. I mean, not very often now can I actually do a decent consultation without the task reminders and the last blood result. And when did you have that cardiologist review? What's the medicine you're meant to be on? So I've just got a photo this morning. I've got my second screen right next door to my AHR where the patient normally is. And it's just a natural consultation now. And we've decided as a practice, we're not looking back, people choosing, and about 50% of the time they're wanting a video consult instead of coming in. And we're not going to get really complicated on who should or who shouldn't. People decide, and then most of the time they decide very well. Very rarely I say, actually, I think I need you to come in to see me, because people know. They sort of decide very, very wisely what kind of consultation they want. And we've gone on from there, and it's made it very easy. The difficulty is joining up the appointment with the EHR appointment. That's still the struggle.
Yeah, thanks, Carl. And Marshall, did you want to add anything to that before we move on?
Well, just specifically in terms of the question, I mean, I think one of the difficulties, and Carl's pointed to this, is the products are all evolving so rapidly. It would be very difficult to establish any platform of advice that didn't date within a week or two. And of course, it depends a little bit what your priorities are. And of course, GPs will place a lot more weight around cost than others, and it depends on who's paying and some of those sorts of issues. I know Faustin would be a big man for security and privacy. Probably GPs actually, while we say we really care a lot about that, we just want the thing to work and for it to be relatively seamless and intuitive for our patients.
Yeah, and actually that's an excellent lead in, because I thought we should cover off security now. There's a few questions coming in, that are security related, and so we have Faustin here, but obviously Lucy and Roy also got expertise and knowledge in this area. But I think Faustin, I'll throw this one at you in terms of in terms of the cloud risk assessment. One of the things that I find with when talking about this sort of thing is, so how is that most simply understood, and without going down into too deep a hole, you know, how would someone, you know, running a clinic or wanting to go through and do a CRA, you know, actually go about it without it taking up months or days, perhaps years?
Yeah, so probably I would not advise, you know, GPs and sole practice owners or you know, very small organizations to undergo themselves a cloud risk assessment, especially since they might reinvent the wheel. Someone else in our community might have done that already. So actually reaching out, as was already mentioned before, I believe by Andrew, reaching out to your community, either your PHO or I guess your peers, DHB, the ministry, or in fact us. We might already have a cloud risk assessment completed for the platform that you are looking at. In a nutshell, what the cloud risk assessment is, it's a couple of questions, about 112, I believe, that would cover most of the important areas for digital technology, a service in relation to security, but also governance, incident response, really a lot of areas that you should look at when you are selecting a new product. And I am aware of, for example, Zoom has undergone this process. And again, it is a very informative process that will show you what are some of the gaps, maybe some of the areas where you would need to put more, you know, more restrictions, more thinking on if you really want to use certain functionalities, or maybe you leave it for later on, and also some areas where you are quite confident that you have no issue. For example, with Doxy.me, I understood that they are not storing any information whatsoever. So at the end of the day, what's there to worry about, you might say. Again, I believe there are some risks that need to be understood and obligations on both sides, the customer or the GP, whoever is using the service, and also some obligations from the suppliers of those services. So as long as, I guess, both parties understand what are these obligations, that's basically the role of the cloud risk assessment. As it was mentioned, a lot of these platforms are continuously changing, especially these days when they are, I guess, in focus, not just by security aspects, but by the bad guys, which are trying to exploit them to get your data, or I guess get some financial gains. So I would keep an eye out on what the vendors are actually recommending as best practices, and also possibly you know, working with some organizations that have some experience, or with your IT provider, again, PHO, DHB, that might be able to advise on again, on specific risks, and also ways to work with those risks.
Great, thanks. Lucy, you look poised to jump in as well on that question.
So the cloud risk assessment and the privacy impact assessments, they are done related to the environment that you are working in. So we should be sharing the information, but you cannot just take someone else's cloud risk assessment or privacy impact and say, it's been done, that's it. It needs to be looked at in the eyes of how you're using it. And, you know, they also need review. You know, we did the cloud risk assessment and we did the privacy impact assessment on Zoom when we were selecting it. But our selection process was a couple of years ago now. We need to revisit those type of things because things change so quickly. And, you know, the security, the encryption behind Zoom is currently changing. So it's not static either. But use your colleagues who are in other practices, that are similar to yours, and also the people that you're going to actually be communicating with. So the clinicians are communicating with patients, but we're also communicating between organisations and things as well. So utilise the experience around, and the Telehealth Resource Centre will often, we try to put up things there that can give you some guidance or give you some context about who you can talk to about things.
Yeah, thanks, Lucy. And I think we get quite wound up about the CRAs, and in a good way. They're something that can't be ignored. But I'll probably chuck this one back at Faustin or even Roy, and sort of simple security 101 things. If you're really at the very fundamental level, what should you absolutely be doing in your day-to-day practice?
Okay, I can quickly cover that, and then I guess maybe others can argue with me how feasible some of these tips are. I'm hoping that most of us are aware of CertainZ and their top 10. If not, happy to, I guess we can throw the links in the chat. They have a top 10 security list that's based on their experience seeing, I guess, across the New Zealand landscape, the types of attacks and also the types of measures which are most effective to prevent those attacks. From that top 10, just to be short, I think I will mention only 5 that from my point of view, I think these are really the basic measures, the 20% that can mitigate the 80% of risks. So first of all, I would mention securing your accounts. So that means, for example, changing your default passwords, having a decent password for an account, and not using, for example, if you use a specific service for patient treatment or for remote consultation, probably you should not use the same password that you are using with your other accounts, especially your personal ones. If possible at all, implement MFA, multi-factor authentication, or dual-factor authentication, getting another prompt as an SMS or on your mobile. That's very effective in case someone still manages to get hold of your credentials. So again, securing your accounts should be your top priority, since obviously that's the way bad guys will get in. Also, next in line, which is, I guess, everyone should know, since it's really banked by security experts often, it's installing software updates. And I've seen, as Lucy was mentioning, Zoom in the past month has had so many software releases just to improve their security. Same with, I guess, your browsers and your operating system. So it's really important to install those software updates, since will protect you from a lot of attacks. Then maybe the last 3 would be to secure your devices and network. So have a decent antivirus, a decent firewall, and again, for all of these devices that you are using, try to change the defaults. Then finally, back up your data. I cannot say that enough. That's a no-brainer, especially if you are handling patient information. You should not have any excuse for not doing that. There are quite cost-effective measures. You might already have a license that allows you to back up your data. So just do it. It's really important, since it's one of the last measures. If you still have an incident, you will be able to quickly recover. And finally, I think really what we are seeing from our perspective, it's I guess a tip on staying alert on scams and phishing and all sorts of attacks, and perhaps allocate some time to inform yourself on how to spot a phishing email. For example, what's behind what's in my background? It's a typical phishing link that it's using Zoom to actually gather your credentials. This is an actual attack, and I think as the more we use this technology, we need to be aware of, I guess, the risks that are natural to it, and you know, do a little bit of training on how different products works, what are their security controls, and I guess best practices that all of the vendors, I'm sure, are recommending, and then some of them might be just a tick box away for you to enable.
Mm.
I hope that was short and concise, but yeah.
Well, there's a lot to cover off. Yeah, it's and I think that's coming through in some of the questions in chat. That you know, that seems yeah, because there are lots of components to this discussion, and particularly around security, that you know, it's not quite one size fits all, but some key things that do need to be covered off. Roy, did you want to add, you know, from your experience?
Look, the only thing I was going to add was, you know, from a different perspective around privacy is, you know, what do we do currently with the telephone? You know, we have conversations over the cell network. We you know, use them in all sorts of ways. But there's also what's happening outside the room. You know, if people can hear you, I mean, you've got to be pragmatic about your approach. And I think, as Faustin says, being aware of the situation, the risks, I think is really important. Etiquette can play a big part as well. So during a video consultation, declaring who's in the room with you, for example, is a start. You know, there's some just sort of basic, very pragmatic, you know, sort of rules of thumb that really can steer you in a good path.
Yeah, thanks, Roy.
In addition,
oh, yeah,
and in addition to that, monitoring if your software has the participant list, just monitoring that to make sure no one has joined that you're not aware, and try to lock the consultation if you can. But always, we like to interact with patients and things, so they need to be informed about what the risks are. So if you have informed patients about the risk and they choose to do that, then that's fine. And that will cover off a lot of the platforms. You know, if a patient wants to use FaceTime, you may not be particularly enamored about it, but if that is the way that they can interact with you and they understand the risks, then they've made an informed choice.
Mm. Yeah, thanks, Lucy. That's actually a really good point. We'll hold that. We definitely will come back to it very shortly. But I just want to, before we go any further, is welcome our additional panelist, Kyle Ford, and thanks for jumping on board and joining us tonight, Kyle. Can I just do an intro and just let us know a little bit about your background?
Yes, Kyle Ford, CIO for Well South Primary Health Network, all the way down south. Also sit on a couple of national boards with Ministry of Health, and have been with the Telehealth Leadership Group for around about 4.5 years since I've been in primary care, moving from the private sector, which has been extremely exciting.
Yeah, thanks, Kyle. And you might have picked up we're sort of covering off sort of some security questions and that whole area of security, and just popping back to going back to Lucy's point about, say, okay, the patient wants to use FaceTime or maybe even WhatsApp, something like that. I think actually yesterday there was a conversation, Carl Cole, that you were talking about your own experience with that, and talking about informed consent and really putting it back onto the patient as long as they understand if that's what they want to use. So do you want to expand on that? Just maybe cover that off while we're on this topic.
I think I was also talking about that. There's always been a joke I've had when I've learned about the concept of informed consent teaching students, is that some people think informed consent is giving the patient enough information until they agree with you. But informed consent is actually informed consent, and when is it there? And but I would say and when it comes to information, I'm not a salesperson for DoxyMe now. I'm not got shares in it, but there's no way I'd do anything but DoxyMe in the last month. someone tries other ways. And in fact, a couple of times today in the phone call, I said, look, can you just call? Because I couldn't quite remember them from the voice, and it was so much better to see them. And I remembered I was seeing the patient once in a year, and they had an eye infection, and I could diagnose it over the phone. And what I was liking about that is that people do trust you to do that. So when it comes to a lot of South Auckland patients, that they'll just follow the link you give them. So you don't have time to discuss the pros and cons of this guy's communication. And in reality, we don't do it about telephones. How secure are different phones and web phones, and who's in the room when you're discussing with them? So I'm finding the video link just much more secure, because I usually recognise faces more than names. Anyone who works in GM practice for a while, names start to get a bit things, but I recognise the face. That was a problem. And it's more personal. And I'm finding I'm doing a lot of mental health over the video, and that's much better by video connection. Anxiety and talking through some cognitive behavioural therapy and what we can do. And I was surprised how much ACC I can do over video. Can you stand up? How's your back? What's the shoulder like? And you just improvise. And what I've liked about DoxyMe is I was a Zoom boy, and Roy and Lucy will tell you that I was definitely a Zoom boy for last year, and I thought I'd just have to use Zoom. I've got an account. Is that we talked in the chat there is the patient experience. I have not had one patient not be able to join. I kid you not. I hadn't realised the importance. Well, I had, but I hadn't experienced the importance of the usability when you've got a bunch of patients out there who don't use Skype, don't use Facebook. So I've had 80-year-olds. If I've got a smartphone, it works. That works straight out of the browser. You don't add a text message, I think, 5 minutes before the phone, the appointment, and it runs inside the browser on the phone. But what I would say, I saw a question, is the biggest inequity problem is the data. So people pay in small amounts of data, and I want a campaign for having a white listing for medical centres somehow, that like Facebook, who cares? You should be able to get national Healthline and all healthcare providers free data as we go forward. And I'm sure other products will catch up with the health usability. It's also got waiting rooms, which is just a fantastic idea. I thought, how can it be secure and HIPAA compliant with a waiting room that's the same link every time, that goes straight in, and it's got your little waiting room, but they take a photo as they come in, and you have to pull them in. And you can only do one person at a time, and it's impossible for another participant to come in. And that waiting room can be chatted with by another person, and by a nurse or someone to pre-enroll them. And it also does forms online for consent, so you might want to fill the form in beforehand. So it's got that whole workflow bit going. So I went for, it's American, HIPAA compliant, it's a subscription service, therefore it wants to be around for a while, it's mature, and it's the patients first, not what we like.
Absolutely. Marshall.
Oh, well, I'm a DoxyMe convert as well. So, and again, I don't have shares in the company, but I forked out for a clinic account, which wasn't a small sum of money. And again, I think some of the points Carl make around workflow, just to emphasize a couple of things, I think having an app agnostic platform is great. So we don't need to download anything. We don't have to fiddle about setting it up. It runs in most browsers. There's some little tricks around that. So I've had a few people want to connect with a PC, and it basically only likes Chrome or the new Edge version of Chrome. And you can also use one or two others, but it doesn't like Internet Explorer. But phones are fine. We've been, you can text out of DoxyMe Clinic invitations, but we've got the text invites running out of our MedTech appointment reminders. So,
So Marshall, I should have mentioned that. To me, that was one of those killer app moments, because you're in the EHR the whole time, and that static hyperlink that's in your template in your text that you just send out has been a game changer. People just then press the text button and away they go. Sorry, Marshall.
Yeah, so we've kind of jumped forward a little bit from that. So those reminders go out, but we also have our reception trained if they're booking appointments on the phone to prompt the patient. Would this be something we could do on video? And they get a little bit of, well, I don't know how to do that, and so they'll get a little talk through that. It's really simple. This is all you have to do. So that's, and I think being able to send a link in advance, people sort themselves out, make sure everything's working well in advance of the consultation, which was one of the problems we had with the Manage My Health MedTech solution, which was getting people actually sorted before their appointment was due. So it is working well. I think you can probably achieve a degree of Doxy.me usability with Zoom. I just posted a comment that you can set up virtual waiting rooms with Zoom.
Yes.
And well, depends, but probably Zoom is cheaper than Doxy.me, at least at a clinic account level. I don't think it's quite as swish, probably not as seamless, but I think if you worked at it, you could get most of the way there on Zoom.
Yeah.
Okay, and actually, I think we've quite nicely sort of transitioned over into talking about software. So we move on. Let's carry on that theme. So, but when you actually, like you've considered, say, what works best for you guys, say Marshall and Carl. If we look at it, say, at a PHO level, bringing Kyle into the conversation here, some of the things that you've done down in your area in Well South, in terms of what your the GPs in Well South are using. Did you go through any sort of a process with them, or was it left up to them to decide what they would use?
So telehealth has been relatively hard to get off the ground. Everyone knows that across the whole country. And then we had a pandemic, and then everyone wanted, well, it was driven by the college, and we had 48 hours to get up and running in our district. So you don't have many options, and Doxy.me, everyone's talking about that, but it is a platform which uses it's not a proprietary technology, it's a technology that's widely used in lots of applications around the world. It just so happens that a lot of people use it in New Zealand, and it's extremely easy to use. And I guess a lot of the time we've thought about the GP and making it easy for them. However, making it easy for the patient is absolutely critical, and I think that's where Doxy has been a real enabler for patients. They just have to click a link, type their name in, and then the control of that whole experience goes over to the GP, and then he brings them into the waiting room. So it's extremely good patient experience, and I guess that's where the feedback we've had. I've got a survey which we did across the district throughout the 8 weeks of virtual consultations through the Telehealth group, and hopefully they can publish it, which was done across the whole district, and it was extremely positive. 70 to 80% of patients would welcome it back again. So, and some of them don't want to change back. 160 doctors use Doxy.me in our district. The first 6 weeks was about 2,600 consults. So it was significant, and that's actually a small portion of telehealth for us over those 8 weeks. Majority of them were by phone, and that was acceptable. I think where the issue became slightly greyed was how GPs charge, whether what's appropriate to charge for a phone consult that goes for 2 minutes, or if they have phone consult and then they have a face-to-face, what do you do with that? And I think we really need to provide some guidance or some best practice around that piece there, so that GPs do have a bit of guidance around that area.
Yeah, thanks, Kyle. And a good question here from Cindy, actually. She's referring particularly to Doxy.me, but I think it's relevant no matter what system or software that you're using. She says the bulk of our patients are over 65, not terribly tech savvy. Interested in particularly Carl and Marshall, your thoughts on, has it been an issue for your older patients, and how have you managed that?
Marshall?
I think Carl mentioned that he had some elderly patients using it. I think the oldest person I've had on was 84. I think we forget that some of them are actually very tech savvy. My dad's 89. He's pretty good on an iPad. He uses Facebook Messenger. He uses Zoom. He got very keen on his iPad when he discovered he could get the newspaper online for free. Even better when he can make phone calls to his family in the UK for free. So and they have time to figure some of these things out. And he found it a little bit overwhelming and threatening to start with, but with a little bit of guidance, he got there. And I think that's a daily experience.
Yeah, I agree. Certainly the younger today, mostly people who are mobile, it's too easy, and they're asking lots of questions and switching. I've found a test for me now is, do you use text? Do you have a phone? Yes. Do you use text? If they do that, they can use this. And that's what I found was the game changer. If they had to also text, use a phone, and download an app, put a password into an app to then become a client to be able to join, that took out a huge population. I'm an old papatoe. Over 20% of my patients are over 70. I've got 16 people over 90. Really old papatoe, so a lot older. I've got an age curve that does this. That's, I was really thinking I'm not going to get away with telehealth very much, but if they can text, they can use Doxy.me, and that was the key difference. There's also, on the web link, there's a button they go into the waiting room. So, and that's what people are now asking for. So, yeah, I don't think age is a barrier. It's more how IT literate you are, and you'll be surprised how many elderly are actually able to use a smartphone text. They'll just say no because they don't want to look stupid, but they actually are communicating with their family. It's the way they connect. And as long as they don't have to download an app and put another silly password in, they're okay.
Great, thanks very much.
Passwords, I think, are quite a barrier. They need to be able to just click on a link. Yep. And that's one of the struggles that we've had when we've been looking around what should we be turning on because it's advised from security versus what's actually pragmatic. And passwords are actually really, really tricky. And the app, and having to download an app on a mobile, that is quite a barrier, particularly when they've been loaned a device by someone, the grandson's given an older person, they didn't realize, they don't know the accounts to be able to download that app, and that becomes a barrier. So I think we're going to have great benefit from the work that's happened in primary care, and particularly with Doxy.me, and I think that will assist our uptake in the secondary care, that people have actually had some experience with it, and it will make it easier for us from the secondary care area.
Scott, just a point from me. These products are, software is really easy to implement in some ways. It's cheap often, it's often free. So as anybody can get maybe 4 or 5 different products and try them. So it doesn't have to be with patients, it could be with friends, family, or whatever. So I suggest people try the functionality. You can't really learn or get a good feeling for it by just watching or listening. Actually use it, try it, do it. On the telehealth.org.nz website, and I'll post the links, we do have a little bit of information about Zoom and about Doxy.me. Doxy.me's given New Zealand some preferential pricing, so the information's on that. And we'll build that out as other products kind of surface and are used predominantly within New Zealand. We'll start to build more content around those. But at the moment, there's telehealth.org.nz/Doxy.me and telehealth.org.nz/Zoom that you can have a look at. And I'll post that in the chat.
Yeah, and those are really good points, Andrew. Thank you for that. And probably jumping back to Kyle, just following on from that, you from your experience, what you're seeing, clearly we've gone up quite a steep curve just with over about a 7-week period. Sort of looking toward the future, and so the maturity starts to not flatten out the curve, but in terms of people being used to having a video consult as a patient or as a consumer, and doctors and clinicians being used to carrying those out. Where do you see this heading with various software and products?
Yeah, so software and products, I think I'm a relatively agnostic person, so I like to think that integration is probably a key part of how we operate in the healthcare sector, and I advocate for trying to transform that and making sure that some of the abilities, so the capabilities that are behind Doxy.me, making sure that that back-end infrastructure can be introduced in other applications that are around, you know, our PMS systems, and not just in primary care, but in hospitals, etc. And I guess the other part of that is ensuring that the model of care supports it, and the funding model that supports that model of care. We can't expect the same model, funding model to support virtual health if there is no funding to support that in general practice. So there needs to be something to, you know, provide general practitioners and clinicians a mechanism so that they can enable themselves in virtual care. And funding goes a long way, and I think somebody mentioned before around the cost of you know, some of the products that they're using. It's quite significant. It's not a small amount, and for very small practices, it's quite a steep curve for them financially. But if we can, you know, there may be funding that's available through the Ministry of Health, which would be great, as part of the capitation model, or even part of the funding model, that'd be exciting. I'll just talk a wee bit about, sorry, about the equity bit, because I do have a, I guess, a bit of an interest in that around, and right down to phone, you know, because not everybody has minutes on their phone, so there's an equity gap there as well. I think making video free as part of the, you know, the zero data offer or anything like that is going to be quite a hard ask. So I wouldn't go setting too many expectations around that, just for the simple fact that the mobile networks will get completely saturated. And I think that's the biggest worry with it. It's the unknown, and the telcos are relatively scared of that part. But I completely agree, equity is a massive gap that we need to try and solve.
Yeah, excellent. And just on the topic, and before we move off that, there's a couple of questions that have come up. But is there a, and this might be for Carl, Marshall, or Kyle, is there a Doxy.me user group? Or are you learning this as you go?
I'd say it's exactly what Andrew said. I'd heard about it from Jamie Shepherd. I was an advocate for being telehealth for years and years, but just too busy. And then the bit of just, I got my free account. It was free, and then if you commit to professional, then I've got a clinic account. It's month by month, and $300 to set it all up. You go, well, but it's not that much. It's fast, and it's got the subscription, and you can learn on the fly. And it's best to give all the staff a trial in, and we learnt how to do the text, and hey, come join our meeting now for text. And we just learnt by trying, and you know, most people, we've all been patients and we can experience it, what it's like, and it was just all by trying. It's not that hard, and you start to see what we're talking about, that waiting room and that part. I think it's got its limitations. The video is not nearly as good as Zoom. It can't do this kind of meeting as well. It's not made for webinars. It's made for that very specific workflow to come into a waiting room and see, and then we go through a few waiting rooms and then managed. I think the biggest thing we could leverage, I hope, of COVID is a redesign of how we interrelate as health professionals around the patient, and have teams and whether it be specialists or multidisciplinary teams around the patient's need, and attack inequity that way. So you don't have to be in Auckland to get your you know, skin cancer assessment for your difficult cancer in your eye. You don't have to travel and take 2 weeks and get behind the rest of people. So proximity basically doesn't give you the advantage. So geography shouldn't affect your access to assessments. And that's really the interactions between us all as health providers. I think that's where we really could see some massive gains of our rural communities being able to go to the local doctor, plan a visit, and get the same care as if you're living in a central city. That's what I think we really I think we're going to sort this bit out, what we're talking about, actually, to tell you the truth, but I think we're still, the disaster, I feel, is if we carry on the way we refer to local hospital inside of DHBs and don't take the chance to sort of level the playing field across New Zealand and have national services.
Yeah, good, interesting. Thank you. And Marshall, thanks. You've put in the chat there. There is a DoxyMe user group on their website, so so people can refer to that. There's one question here that let's flip back a little bit back to the security question. I just don't want to lose this one. It got quite a few votes, and Faustin's really chaffing at the bit to answer it. So can the panel please clarify what the expectation by MOH regarding the security level of the telehealth platform for common situations, such as GP consults and therapy sessions, e.g. when is HIPAA compliant, required, etc. So Faustin, I'll hand that's a question right up your alley, isn't it?
Yeah, or I guess I cannot speak on behalf of the ministry, yet I am aware of their minimum security requirements that they have, and happy to provide the link, I guess, after the webinar. Also, with the telehealth group, we provided guidance and advisory, first of all, in, I guess, in general terms, since we spoke a lot about, I guess, solutions and their security. What I want to make clear is that there are some obligations on each of the participants, both the, I guess, the GP clinic and the patients, to actually follow best practices. Well, as we discussed before, this is a little bit of a moving target. Every day we learned on I guess, on Zoom or other platforms of their potential risks, and they are continuously improving those services. So while I guess nothing is perfect, and there isn't such a thing as 100% secure services, and there will never be such a thing. I think just using common sense, applying, you know, maybe not the top 10, maybe the top 5 measures would satisfy to a great extent the requirements from the Ministry of Health. Maybe my final point on this, I think we should not see security and privacy as some tick box exercises just to satisfy some regulatory requirements, but really something that all of us need to follow so that we are protecting patients' privacy. Yeah.
Yeah, thank you for that. And there's while you were talking, there's also some more chat on the side there, just regarding the user groups and so forth. So Andrew, did you just want to touch on that? Or you made a point about, you know, looking at various specialty groups and user groups.
Yeah. So we have been thinking about that, because we've done a few stocktake surveys over the years, and so we know who's doing what where to a certain extent. And we've had a few requests from, say, different nursing groups, for example, to know about other nursing groups doing a similar thing throughout the country. So we have been looking at how we could facilitate some of those groups, whether it's a forum or a group, or whether we have some specific webinars for that particular audience. So certainly tech, or, you know, DoxyMe or a Zoom one, or whatever other platforms people want to suggest, we'd be certainly interested in doing that. Yeah.
Excellent. And what's the, and this is an open question really for any of the panelists to jump in on, what's the role here of the PMS system that you may be using, the portal as well? So, we've been talking about DoxyMe and Zoom, but the PMS systems themselves, or the portals, have a video facility. Do we see that progressing? I think it comes back to that maturity stage of more integration, coming back to, and mentioning Kyle's point, integration and interoperability. So, and the transferability of the record. So, Kyle, you're putting your hand up to answer that one, or to kick us off on that one anyway. Yeah,
well, I was just going to say that I'm not quite sure what. I know Medtech have got a product. I haven't used that. Some of the GPs might have used it. I'm not too sure about it. I know that some of the portal vendors, one of them, Auckland, I think that's where Jamie Shepherd may have introduced Carl, which was in their portal at their general practice.
Yes.
And they introduced the link into the appointment system, which was quite handy. It was well integrated. I think it was a third-party portal vendor as well, and that was integrated into the Medtech system. I know Medtech have their own, but I'm not quite sure about that one. But I know that worked quite well, and it was good for a patient experience from their perspective. I think what I'd like to see, because I'm relatively analytical around this, so it's quite separate still. You basically bump outside of the PMS into docsy.me. You're still operating like what I'd like to see. It doesn't have to be inside it. It can pop out, but I'd like to see the record go back into the patient management system, just as a text record that it happened. And I think you can do that with the appointment, but even writing a consult note at the end of it so that it published it back into the PMS. Something simple like that would be, I think, relatively valuable for practitioners.
Kyle, that's the integrated Doxy.me into Indice up here for that reason. And I saw what you're saying for EPIC and the NER project when we did an evaluation of implementation planning study, and that actually uses Zoom as the white box behind a very smartly integrated system that's actually inside. It just pops up a window inside your examination, so you can be looking at the notes inside a floating window. And then you can take photos remotely from and it gets stored straight in as a photo. No saving file, import file, it's just there, drawn on by the patient and things like that. And I think that's where we need to get to, but of course, understand the sort of integration challenges there of we don't have agnostic ways of exchanging stuff, but that's exactly where we need to go. And it would be part of, you wouldn't think any more of it than now sending emails. And I do remember a day when a doctor was telling me once I'd never email a patient, never. And I think it's going to become as integrated as emails are.
Well, in the last 8 weeks, I've seen huge transformational change within the ministry to open up the APIs. And I think what that's going to do is it's going to drive different vendor behaviours. Completely. Like, I don't need connected health for about 2 or 3 services that are required access at the Ministry of Health anymore after 8 weeks. We've been striving for 4 to 5 years to make that happen. and then you ask yourself, well, do I really need this anymore? So I think they're actually going to try and drive change from the top, from the centre out as well, which I think is extremely helpful.
Yeah, that's really good. And also, by the way, for people, there's lots of great questions coming through. We've extended this session to 8:30. We will finish pretty much on the dot of 8:30, which is only just over 15 minutes away. Any questions that haven't been answered, I believe we'll be extracting them out of this program and trying our best to answer them separately. So there's a few technical questions coming through, some sort of grassroots sort of questions regarding, if you've got 12 GPs, do you have to buy one account or 12 accounts, that sort of thing. We won't get into that tonight, but I think those are good questions that we can probably answer separately to this. I was going to move into just hardware, and I think Andrew, you had, at the time when effectively GPs' doors were being closed, there was just this massive lack of cameras and monitors and so forth. So hopefully we've got through that. But let's touch on the hardware aspect, the importance of it. What you absolutely need, what might be a nice to have. I'll pass that one over to you.
I don't know where to start. We could have a webinar just on this, couldn't we, really, once we talk about hardware. So I suppose there's a few things along the path, isn't there? There's connectivity is the first thing for me. So patient has to have connectivity, and you as a clinician has to have connectivity as well. And that has to be of a reasonable standard for a suitable consultation. And that depends on what's been talked about, isn't it? So some consultations, if you know the patient well and it's just something very simple, then a less high definition kind of call's okay. But if it's a newer patient, then maybe you want to have make sure you've got a better connectivity. So connectivity for me is good. It's always good to be wired rather than Wi-Fi if you can. All those kind of tips and tricks are really useful. And then we've got to think about the device. It was interesting, the poll that we did for some people before the session, we asked about the age of PCs because we're asking the PC or the computer or the laptop or the tablet or the phone to do a lot. And there was quite a few people answered that their device was 6 or 7 years old. So I suppose all these things, they're additive too. So if you take into account the connectivity, the device, the camera, the audio, and you've got down the bottom the minimum standard on all of them, then that's starting to add up to, you know, maybe not a very good experience for video. But if you've got pretty good, you know, connectivity, pretty good device, and your camera might not be as good, then I think overall you're going to have a reasonably good performance. I don't know, maybe we talk about individual devices. So cameras, we always think about cameras are important. A lot of people will be using, and I think it's good for patients to use a device like a phone or a tablet. The cameras are integrated, the mic's integrated, everything just works. But often it might be the clinician then where we're on a computer or a laptop, and we've got to start thinking about how all those individual things are performing. So your camera, often the integrated camera is okay. But an external web camera is generally better. A microphone built into your laptop might be okay, but if you can get an external speaker, then you're certainly going to have much better sound quality, and you're going to have a much better experience for people.
Yeah. I mean, I'd sort of add to that, Andrew. You know, I think you know, starting simple is good, but don't undersell yourself. I think particularly in the audio department, it's very easy to think you're okay until you move away from your very directional laptop microphone and you're over here and you can't be heard by the other person and you're already in the consult, or, you know, it's kind of, you know, you're in there and it's kind of too late. So we definitely suffer in our organization from older machines. It's been a real bugbear for us. And yep, our ages are 7 up to 7, 8 years old, and you know, that's a real problem when it comes to using, you know, video conferencing software-based systems. And you know, we've had to, you know, spend money on upgrades, avoid using certain machines, using, you know, equipment like this for microphones and speakers, or you know, or cameras that add on. But look, it's worth investing a little bit to begin with, because you know, it can very easily go wrong when you least want it to go wrong, and so a little bit of investment can go a long way.
And Lucy, did you want to add anything?
Yeah, COVID was a huge challenge for us because the amount we had to ramp up to do telehealth, the supply chain for the equipment, for integrated monitors with speaker camera mics and them, webcams on their own, headsets, everyone was wanting it, whether we were in health or not, and trying to secure and the continuous supply to be able to extend it was a huge challenge. We've found that in a clinic room situation, that the integrated camera speaker mic is a very good device because it acts as sometimes the sole, but usually a second screen in the clinic. And we haven't got lots of different peripherals that, oh, that's not working because that's not plugged in, or that doesn't have a driver. It's all in one, and it's less likely to have pieces of it walk. So in that situation, but as we got into bigger spaces where we were trying to do keep people spaced, but a number of clinicians doing collaborative work, we needed to use more bigger technology, and so we actually needed a range that was fit for purpose. In some ways, getting patients to or clinics to use devices such as stethoscope, you know, telestethoscopes, or that type of thing, really that was not important. It was actually about, was there a method of taking a blood pressure remotely, the weight scales, temperatures, that type of thing. And particularly for our chronic patients, some of them we issued blood pressure machines and weight scales to in the early part of COVID. And it's about the change in those recordings, not the actual recording per se. So if patient scales at home weren't calibrated quite right, it was actually really, was there a change in things? So the peripheral technology has been a lot less important for us in this situation. But going forward, as we connect to different centres, different DHBs, where the patients can attend and not have to travel to us, we're probably going to need those centres to have some of that additional biometric stuff there.
Those devices, yeah, and I think Carl and Marshall, you've been putting some good points in the chat box there from your own practical experience, haven't you? So, did you want to expand on any of those before we move
I
on?
agree with Lucy and most things, and we've been through this before. It's like the sort of fancy connections really aren't needed. And I'm a big believer in having people and patients self-manage, and they write their blood pressures down and they own it, and the same with doing a pulse and weights. I've found it's valuable that you're checking in as a coach, and it's much easier to do it that way. The best story I had so far was someone outside the Auckland region had gone to Waikato with a very bad immune problem, and they had drops given to her, and she was just in the first week of lockdown, couldn't travel, and she needed them sent to her, and I can't pronounce, let alone spell most of those drugs. And I had to actually, she showed me on the camera slowly as I tried to spell out these very long rheumatological and eye drops that I managed to get up and then get sent to her in Thames. I think it's the video and is the best thing. When it comes to integrating, and that's why I'm such a fan of texting to smartphones, that's when it doesn't go wrong. Generally, if it's a laptop or PC, someone's played on a game on that PC and the microphone's being taken by a streaming service and they can't hear them, and in that silly, I can hear you, I can't, and it just doesn't happen on smartphones. And it reminds me of a story of if you try and get the best gearbox and you get the best engine, you might get a BMW engine. If you want to get the best body, it might be a Lamborghini. You put it all together, you just get a big pile of crap. And yeah, really, when it comes down to these devices, I've found if you can get an integrated, my 7-year-old MacBook Air is perfect compared to using people in my practice have tried to get this camera and that speaker, and it just ends up being blah. Integration is the way to go nowadays. It's not that expensive. Make sure it's got a good noise cancelling microphone, and you'll be away.
We'll just cover off a couple of seemingly small things, but I think they're important. And I'll chuck this one at you, Marshall. Should we use a virtual background?
I don't like them. Well, I think I've played with that in the practice, and I think patients find it actually quite reassuring to see you in your consulting room, and they can see a familiar environment. So what's behind them is, the consulting bed, the curtain, the desk, whatever, but it's a situation that's very grounding. So they can say, oh, it's my doctor, he's sitting in his consulting room, it looks like the real deal. So no, I don't want to see a picture of him on the beach at Fiji on a holiday, because that's just going to freak me out. So I think those are cues to patients to say, this is a real consultation, this is a real doctor. He or she is sitting in a consulting room. So I think for face-to-face patient consultation, I don't think a virtual background's a great idea. And of course, they're a bit cool, but unless I think the software-based ones where you just ask Zoom to pop it in don't work that well. Half your head disappears. It's actually more distracting rather than less distracting. I think if it's a fancy hardware-based one, you might that they work better. But as I say, I'll go back to what I said originally around patients identifying with the environment as much as they are with the person doing the talking.
It can also chew up resource as well. So it can affect the quality of your call because it does have to render that.
Yeah, that's fair enough.
Yeah, that's a really good point. I think, Peter Lane, you seem to have it sussed there where you take a picture of the consult room and then do your next consult at the beach. So, but keep in mind, you are going to chew up some resource on your machine. So anyway, just one final question here, and then what we'll do is just do a quick round robin of all the panelists just to do sort of one final point that you might want to make before we close off. But I've seen this question come up in other discussions about the possibility of patients recording the consult without the GP or the clinician knowing, and then how that might be used or misused. Is there experience on that or thoughts on that?
No.
That's actually something that we've been asked a number of times. And I think when you are in a consultation, you should always be introducing the people that are around you and asking who is there, and actually making it very clear if you are recording, and the fact that you can ask them, are they, is this being recorded?
Yeah, I think so. That's it's a tricky one, isn't it? We've probably not experienced it much yet. So
maybe this would have also some privacy implications on both sides. At the end of the day, it is a conversation between at least two people, not just one. So I guess we could extend a little bit the subject in the privacy topics for next one. But certainly an interesting scenario. At the same time, I'm thinking if patients would want to do that, I guess under normal conditions, they would still be able to do it. So yeah, I'm not sure if I guess digital technologies or telehealth changes, I guess the interaction and privacy concerns, maybe in some respects, but I guess you can do that in practice or face to face, how you want to call it, as well.
Yeah, thanks, Faustin. Look, we'll do a round robin now just to finish off. Just a quick sort of last chance to say something. Seeing as you were the last panelist to join us, Kyle, I'll give you first shot at maybe your one comment from you.
Oh no, I think I think I was lined up for hardware, but in my wheelhouse it's standards, interoperability, and building APIs. That's my thing. But hardware, it's an interesting one. We've come a long way, I think, in the last 3 to 4 years. I was at a previous engagement. I was actually at water polo training, and I ran up the stairs in my speedos, and just as well as no cameras in the work here, but got up here and left my bag behind. So I grabbed my phone, grabbed a device off the desk, paired them within a minute. And I'll tell you, 3 years ago, I wouldn't be able to do that. I think technology has come a long, long way. Just a smartphone, which I've got on my desk, which you can see me through now. It's very good quality. I can see you guys. The sound's great. I think we've come a long way, and it's the options are available. I think the biggest, as I go back to again, equity is going to be the biggest challenge for our country.
Yeah, thanks, Kyle. Carl, quick last word.
When you think about when you do phone calls, you don't care if it's a Samsung or an iPhone. We've got a lot more maturity in there, and you've got number portability between Vodafone. There's technical differences between them. We're still at that younger age, unfortunately, where there is, you sort of choose a platform that the patients will come on. I do like the day where it's open and they choose what they like, and it's much more choice-based everywhere. But the fact of the matter, if you want to use these portals now, especially in general practice, you've got to choose one. And I'm no fan of DoxyMe in terms of, I'm saying, like I'm not a shareholder, but to me it's just such a clear winner when it comes to workflow to solve me. But I'm on a monthly contract, and I balance out that, but I'll move tomorrow if someone has a clever functional add-on to Zoom, because Zoom's much better from a video streaming point of view. So I think it's about us getting in there and being willing to move, but not waiting forever and being willing to fail. I'm not worried about the privacy and recording things. I've been through that with patient portals, and I'm sure telephones are the same. You know, bad people will be bad people. We're giving them slightly different ways to do bad, but most people are fine. And I think it's going to be a saviour of general practice, to tell you the truth, that we actually are more responsive to patients, give them other avenues, and we're only just beginning to realise that we're going to, we should, you know, I feel like we've stalled for 10 years and we're sort of caught up 10 years worth of what we should have been doing the last 10 years and the last 2 months. And we need to go forward.
Thank you, Carl. And yeah, we'll go in going to Andrew. Just want to emphasise the website, the Telehealth Resource Centre website, and also this is only the third in the series of webinars. There's more to come, so you know, keep your eyes peeled and ears to the ground, because these are really popular and very educational, very informative. Andrew. Yep.
So on that, we're talking about recording. So in 2 weeks' time, we've got our next webinar, and that is going to be on regulation, policy, and all those sorts of things. So we'll have people from the Medical Council, hopefully, and we'll have some medico-legal people. We'll talk about recording and all those good things. So this is a tech webinar. So my tech tip that we didn't talk on, somebody did mention it in chat, is lighting. I like to get a good light and get it on your face. You know, we can't have a light from the back in your face in shadow. Get a good light, bounce it off something if you can, bounce it off the roof, bounce it off the wall, so it's not too direct on you. And yeah, that's me. And don't hesitate to email us at telehealth.org.nz. We'll try our best to answer.
Yeah, that's fantastic. Good advice. And yeah, if you've got a bit of a extra piece of forehead like I've got, and a light right above it like I've got, you can see the effect of bad lighting. So Faustin.
Yeah, maybe since I've seen a bunch of questions related to security and often is put at the expense of usability of this great technology, I really think we should find ways of, if Doxy.me find a way to make just patient interaction seamless, and at the same time thought of all sorts of clever ways to cover security risks. I think other platforms, and I think I guess the users can really benefit from this technology, and I'm happy to see that. I guess there are concerns. I believe that's the start of asking some questions to your suppliers, to your vendors. And in case you have doubts, I just wanted to mention that we do provide guidance. We are happy to answer any of these questions. And in fact, if we are aware of cloud risk assessments or privacy impact assessments, sometimes we are able to share these documents. I guess at the end of the day, the main point is to embrace the technology, but also be aware of the risks and constantly try to educate yourself and your patients with, I guess, with both sides of this technology.
Yep, thanks, Faustin. Roy, we're very quickly going to get cut off here, so
yeah, no, that's cool.
Sorry to push you along.
That's okay. Great questions, great discussion tonight, everyone. Look, two things from me: agility, remaining agile, and what the patients want. We need to sort of keep efforts directed there.
Fantastic. Thanks, Roy. Marshall, big thank you for taking time out of your well-earned break as well.
Yeah, just one thing I think that hasn't been touched on to any great extent is that the technology is the easy part, and it's actually change management within the practice. Yeah. That's the bigger challenge. That might be something we can talk about in the future. It's getting the slow adopters on board, getting admin staff to change their processes. That's a lot more work than figuring out the technology.
Yeah, I agree. Actually, there were questions that were coming up that were actually all revolved around that topic, change management, which is all about people rather than the thing. So yeah, I think that's a topic all on its own. So thanks, Marshall. And Lucy, looks like you get the second to last final say, because I get the last say.
Well, I agree with all those points. I think with the technology we have, we've just got to utilize what it is that we have access to and utilize the stuff that is appropriate for the situation. So there's no one size fits all in this, and the technologies that we use should try to be intuitive. We should not need lots of training on how to use this. So they need to be intuitive, and the technology changes incredibly quickly. So, we're recommending this one moment, and a matter of weeks later, that's actually not what we're recommending now. And we need to embrace and move with whatever we've got access to and continue this move forward with the telehealth.
Fantastic. Hey, thank you. And as I just want to summarize and just thank everybody. It's please just keep your eyes peeled on the website. Look out for the next series of webinars that are coming up. Thank you all for your time. There were some great questions, by the way, too, and I really have to apologize to the likes of Graham Jelly and Emily Gill and quite a few others actually who were putting some good comments, good questions. Sorry we didn't get to all of them, but I think we covered off a lot of the themes in the discussions that we had. So thank you all for being such great participants and fantastic panelists. Good night.